Hello and welcome to our webinar, The Physiology of Life and Death, using TXA in the Field. My name is Robert Moya. I am a EMS instructor, nationally registered paramedic, and licensed paramedic in the state of Texas. Our objectives for today include defining anaerobic metabolism, defining shock, identifying the consequences of hypoperfusion, understanding the triangle of death, understanding the cascade of death, and being able to compare the classes of shock. We will also list the treatments to restore hemostatic potential. We'll discuss the various TXA studies. We'll list the indications for TXA administration. We'll also list the exclusions for TXA administration in traumatic brain injury, and we'll identify the dosage and routes of TXA administration. For years, we've told you guys as paramedics and as responders that your job is to sustain life, to prevent death, to cheat death, to snatch life away from the clutches of the Grim Reaper. You know what? All that is great, but really your only job as a paramedic and as a responder is to prevent acidosis. If you can prevent acidosis in a patient, this will potentially increase their chances of survival. Normally, the body will use something called aerobic metabolism in order to produce energy in the body. As a result of the aerobic metabolism, your body will produce necessary energy in the form of ATP in order to sustain body function. If you're lacking oxygen or if you're lacking glucose in the body then will go to something called anaerobic metabolism. An obstructed airway can cause hypoxia. An impaired lung function can cause hypoxia. Impaired circulation in the form of hypoperfusion will lead to anaerobic metabolism. Again, this anaerobic metabolism still produces energy, but it produces very little energy in the form of ATP. In the trauma patient, the most common cause of anaerobic metabolism is blood loss. This blood loss will lead to shock. This shock leads to hypoperfusion. The hypoperfusion will lead to acidosis, which will eventually lead to the death of the patient. The definition of shock, it varies and depends. One definition of shock is a lack of tissue perfusion at the cellular level that leads to anaerobic metabolism. As a result, again, you have a loss of energy production needed to support life. Shock is most often regarded as a state of generalized cellular function change from, again, an aerobic metabolism to an anaerobic metabolism. This usually is a result of hyperperfusion. As a result of the hyperperfusion, the delivery oxygen is inadequate to meet the metabolic demands of the body. This leads to, again, decreased energy production, which we'll talk about shortly. The last thing that happens is the anaerobic metabolism will lead to the decreased energy production, which will lead to cellular death, which will lead to tissue death, which eventually leads to organ death. So hypoperfusion is not just a patient that's pale, cool, and diaphoretic. We think of the typical hypoperfusion shock patient as they're pale, cool, and diaphoretic, and sometimes that's all we leave it at. We have to understand that pathophysiology-wise and at the cellular level, there's multiple things going on. Number one, the acidosis causes a release of cellular enzymes. These cellular enzymes destroy cell walls that result in further acidosis. It basically results in the release of lactic acid. The other thing that happens is that sodium and water then start to enter these cells. This causes cellular swelling that worsens with overhydration. Again, you're losing intravascular fluid as a result of this cellular swelling. The fluid that's normally in the bloodstream is now starting to go into the cells. What do we do to try to fix hypoperfusion? We immediately start to give large amounts of normal saline. I always ask myself, have you ever done anything to kill a patient? Well, the standard of care years ago included us giving multiple amounts of normal saline in order to maintain almost a perfect blood pressure of 120/80. We now know years later that that was the wrong thing to do. This is basically a vicious cycle that continues. It's going to continue unless the process of anaerobic metabolism is reversed by oxygenating red blood cells and by replacing the red blood cells that are currently lacking in the bloodstream. Eventually, if we don't fix this anaerobic metabolism and if we don't fix the acidosis, tissue will die, organs will die, and eventually the organism will die. One of the other things that happens in hypoperfusion, again, we're talking about inadequate perfusion with anaerobic metabolism going on in the body, is the body is not going to be able to produce efficient energy. Normally in aerobic metabolism, the body will produce 36 ATP, again, energy. In anaerobic metabolism, the body will only produce 2 ATP. So I don't know about you, but I'd rather get paid $36 an hour for my work versus $2 an hour for my work. Along with the inadequate production of ATP, the body is now going to have an inability to produce heat. So what happens when the body can't produce heat? Hypothermia starts to occur. This decreases heat production, and basically the remaining body heat is going to be lost to the environment, which begs to differ is what is the body going to start doing when it starts to get cold? The body is going to start to shiver. As the body is trying to produce heat or trying to warm itself by shivering, it's going to start using the little bit of ATP that is available to it. This is going to lead to basically a negative production of cells. The shivering is going to cause muscles to shiver. Eventually, the shivering muscles is going to break down the cells, which is going to lead to increased lactic acid, which is going to make the acidosis even worse. Along with the loss of body heat, as the body temperature starts to drop, this is going to impair blood clotting or coagulopathy. Therefore, any ongoing bleeding is going to get worse as a result of the coagulopathy. These consequences of the hypoperfusion are basically going to lead to acidosis, hypothermia, and coagulopathy. We call all these three things combined the triangle of death. You'll have energy loss, again, in the form of ATP. It's going to cause hypothermia, which is going to cause shivering, which is going to cause acidosis, which is going to cause poor bleeding control. These are not the underlying cause of the death itself, but it leads to the death of the organism. So to summarize, I made the comment that your only job as a responder is to prevent acidosis. If you don't prevent acidosis, you're now going to have something that we call the cascade of death. Anaerobic metabolism is going to occur. It's going to decrease energy production. This is going to lead to cellular death, which is going to lead to organ death, which is going to lead to patient death. Your job, again, is to prevent acidosis and prevent the death of the patient. So again, we need to understand that the most common cause of hypoperfusion and trauma is hemorrhagic shock. This is the loss of internal or external blood loss. We need to understand as responders and recognize as responders these classifications of shock. Class 1, the body has lost approximately 15% of blood volume. You're going to see a pulse rate of less than 100. They'll have a normal blood pressure with a normal ventilatory rate, 14 to 20. So right now, the patient has lost 15% of their blood, yet we yet to identify those signs and symptoms, those classic signs and symptoms of pale, cool, and diaphoretic. As it progresses, the body now loses 15 to 30% of its blood volume. At this point is when we first notice an increase in pulse rate. You'll see a pulse rate of 100 to 120. But I want you to notice that their blood pressure doesn't change. So at this point, blood pressure is not a reliable indicator of the type of shock that this patient is in. But I do want you to look at something though. The ventilatory rate has now increased to 20 to 30. Why is the body starting to increase their ventilatory rate? Well, we said acidosis is occurring in the body. How does the body try to get rid of acid? One of the things it does is it increases ventilatory rate to blow off the metabolic acidosis that's occurring in the body. This is the first time that you're really going to see mild to marked anxiety in your patient. Class 3, this is 30 to 40% blood loss. You've lost 1,500 to almost 2 liters of blood right now. This is the first time you're going to notice a drop in blood pressure. This is also the time that you're going to notice a marked increase in pulse rate and a marked increase in the ventilatory rate. Your patient is now going to be confused. The last class is class 4. The body has now lost more than 40% of its blood volume. We're talking over 2 liters, guys. And at these 2-liter mark is when we're going to notice a significant drop in blood pressure. This is probably going to be your 80 over 60, 80 over 40 type patients. You're going to see a decrease in the pulse pressure. You're going to see a very marked increase in their ventilatory rate. And honestly, if you were to track this patient all the way to the hospital, you're going to notice that there's going to be very minimal urine output, which I want you to kind of think about something. If the body cannot urinate, the body cannot get rid of waste product. If the waste products cannot be eliminated from the body, you're going to have an increase in, you guessed it, acidosis. Your patient will now be lethargic. Your patient at this point needs IV fluids. They definitely need blood, and this is probably a definite case of a patient that needs TXA. What I really need you guys to understand is that shock doesn't happen right away. Shock is progressive. You're going to see hemodynamic changes first. These are changes related to the heart and the blood vessels. Blood vessels are going to constrict, the heart rate's going to start increasing. The next thing you're going to notice is you're going to notice a cellular or metabolic change. This is direct relation of anaerobic metabolism. The next thing you're going to see is something that we call microvascular changes. These are changes that now start to occur at the capillary level. You now start to have stagnation of blood. You now start to have a buildup of more acid in the blood, and eventually these will all be released to the rest of the body. The body can only compensate for these changes short term. So the cause of the problem needs to be corrected. Otherwise, the changes will not be reversible and the patient is going to die. So the most common way to identify hypovolemic shock is, again, the patient is going to have cool, clammy skin. Their skin color will be pale, or sometimes if it's progressed further, they'll become cyanotic. Really not a blue patient, more like a grayish color where you look at them and you're like, man, this patient just doesn't look good. You're going to see a drop in blood pressure, they'll have an altered mental status, and they'll definitely have delayed cap refill time because the body right now is starting to constrict those blood vessels at the furthest parts of the body. It's important to note that the first organs that are going to be affected by shock are going to be your oxygen sensitive organs. There's a reason that the body shunts its blood to the center, because your oxygen sensitive organs are your brain, are your heart, and are your lungs. And of course, kidneys and other things like that. As it progresses further, the other less oxygen sensitive organs are going to be affected. Again, I mentioned kidneys. Eventually, if the kidneys fail and the kidneys don't dilute and don't remove waste product, it's going to increase acidosis in the body, which is going to lead to poor outcomes. I really want you to take note of this, is that the failure of one major organ system correlates to approximately a mortality rate of 40%. So you're already behind the curve, 40% now. Along with that, if an additional organ system fails, mortality is going to approach close to 100%. As a result of these failing systems, you're eventually going to have something called hematologic failure. This is basically a failure of clotting in the body. The clotting failure can be as a result of hyperthermia, the dilution of the clotting factors because we've given IV fluids, and the depletion of these clotting factors. So we have to do something to try to protect the few clots that are now being formed in the body in order for us to be able to stop the bleeding in the body. So how do we do that? Well, we basically, the first thing we've always done and we've done for years is to administer IV fluids. Recent studies have shown that the administration of normal saline may actually be bad, but we'll leave that for another webinar. The other thing now that we're doing regionally here is something called whole blood. We are now starting to administer whole blood in a pre-hospital setting to our patients. Normally, these patients would have the volume of their system replaced by us giving IV fluids. Well, we gave IV fluids, great deal. We've now increased the amount of fluid in the vessels, but we haven't increased the amount of hemoglobin in the vessels. When we got to the hospital, one of the first things they would do is they would give a transfusion of 1 to 1 to 1. 1 unit of plasma, 1 unit of platelets, and 1 unit of red blood cells. Normally these would add up to like maybe if we were lucky, maybe 200 mLs of fluid combined. With the administration of whole blood, you're getting all 3 components plus additional volume to the patient's blood system. The next thing that we need to do is administer tranexamic acid or TXA to these patients. What this does, it hinders fibrin degradation, which basically says it keeps clots from falling apart. It blocks the activation of plasminogen to plasmin, and as a result, the clots remain viable and help reduce bleeding. You know what? I just threw a bunch of $25 words at you. I suggest that you go and you look up the definitions of plasminogen and plasmin and fibrin degradation. Essentially, here's what it does. It provides a protective net around blood clots. That's all TXA does. It provides a protective net around the clots to prevent them from breaking down. So how do we know that TXA works? Well, like everything else, our medicine is evidence-based medicine. We use current scientific evidence to provide appropriate treatment to our patients. Back in 2012, they had something called the MATTERS study. The MATTERS study stood for Military Application of Tranexamic Acid in Trauma Emergency Resuscitation. What they did is they took 896 consecutive admissions of patients with hemorrhagic shock. 293 of these patients received TXA. As a result, those that were in the TXA group had a lower mortality rate. It was like 17.4 versus like 23.9%. They also noticed that those patients that received massive transfusions also had lower mortality rate of a 14.4 to 28.1. You're looking at twice the chances of survival. In 2013, they had something called the CRASH-2 study. This CRASH-2 study took 20,000 patients, 20,000. They administered half TXA to half the group. They administered a placebo to the other half of the group. The results of the CRASH-2 study basically concluded that early administration of TXA safely reduced the risk of death from bleeding. Well, now we come forward to 2019, which leads to our current based evidence medicine, the CRASH-3 trial. The CRASH-3 trial is still ongoing. I believe they've taken something like 12,725 patients. Of these 12,725 patients, they used TXA in patients with traumatic brain injuries with possible intracranial bleeds. The early outcomes are very favorable. The early outcomes have shown that by administering TXA in TBIs, it hindered intracranial bleeding or further hindered intracranial bleeding. So these were 3 great studies. I strongly suggest that you guys go and do some research, go look at these studies, and go look at the results of the studies. So now let's go ahead and look at the indications for TXA administration. Number one is a patient in hemorrhagic shock or a patient with a traumatic brain injury with possible intracranial bleeding. First of all, hemorrhagic shock. We need to look at their signs and symptoms. A sustained tachycardia of greater than 110 beats per minute, a systolic blood pressure equal to or less than 90 millimeters of mercury. The traumatic event occurred within 3 hours. We can also use it not just for trauma, but for severe GI bleeding or severe vaginal bleeding. The administration for hemorrhagic shock is 1 gram of TXA in 100 mLs of normal saline administered over 6 to 10 minutes. One of the things that we notice and one of the things that we're doing here locally is we're placing a green TXA band on our patients. The reason behind the green TXA band is to alert the receiving facility that the patient received pre-hospital TXA, because the patient's going to require a maintenance infusion of 1 gram over 8 hours. So again, this is going to alert the receiving facility. In the cases of traumatic brain injury with possible intracranial bleed, we are also administering TXA. Again, the indications: a GCS of 3 to 12 at the time of assessment. The time of assessment by the provider, not what was reported to you, because it is possible that someone could have been unconscious with a GCS of 4 that is currently a GCS of 14, and it wouldn't meet indications for TXA. The injury has to be less than 2 hours. Some of the exclusions: a GCS of 3 and non-reactive pupils. Again, a GCS of 3 with non-reactive pupils. Greater than 2 hours from the injury, any seizures, MI, a stroke, the patient's on dialysis, a drowning or a hanging, burns greater than 20% body surface area, or if the patient has received prior TXA. These are exclusions from administering TXA in traumatic brain injury. Again, depending on the reliability of the history, we may or may not know whether this patient had TXA. So how much are we going to give? This is going to differ from our hemorrhagic shock dose. What we're going to do is we're going to give 2 grams of TXA, mix it into a 100 ml bag of normal saline, and we're going to administer that over 6 to 10 minutes. The question that always comes up is, well, what if I have a patient that has internal bleeding with a traumatic brain injury, your multi-system trauma patients? Then what you're going to do is you're going to use the traumatic brain injury dose of 2 grams of TXA and administer that to that particular patient. So that we know that it's really important for us to know the dosages for our TXA. I'm going to highlight it again. I'm going to repeat myself. In hemorrhagic shock, we are going to inject 1 gram, usually 1 vial of TXA into a 100 ml bag of normal saline. In traumatic brain injury, we're going to inject 2 grams or 2 vials of TXA into a 100 ml bag of normal saline. Again, we're going to administer this over 6 to 10 minutes. Basically, what you're going to do is you're going to go ahead, connect a 10-drop set to your normal saline bag, and you're going to open it up wide open. We did numerous trial runs, and during those trial runs, we were able to figure out that the TXA administered itself over about 6 to 10 minutes, just depending on the patient and the patient's condition. So again, hemorrhagic shock, 1 gram into 100 mLs of normal saline. Traumatic brain injury, 2 grams into 100 mLs of normal saline, over 6 to 10 minutes. At this point, I want to encourage you to send any questions or insights regarding TXA to my email address. It's moyar@utesca.edu. That's moyar@uthscsa.edu. I want to thank everybody for listening to this webinar, taking time out of your busy day to further your knowledge and education. I believe that taking this time to listen, to educate yourself, to use different webinars throughout, and learn about current-based medicine practices is really important. It's really important to help with our care of patients. I also want you guys and encourage you guys to seek out studies to question things that we say. I also want you guys to understand that the administration dosages that I gave you are specific to our Office of Medical Direction. So please get with your medical director to be able to find out what their how they feel about TXA and what your administration practices are for that TXA. Thank you very much for your time, and everyone have a wonderful afternoon. Thank you.